All right, well, thank you all. Martha has made it back, so we're going to get ready to introduce Daniel Dawes, the Political Determinants of Health. Very excited. We do have our sponsors that we want to go ahead and thank for this wonderful event. First and foremost, we'd like to thank Martha Monroy at the College of Public Health for bringing Daniel Dawes to us. Such a treat to have a national author and spokesperson here with us today at the University of Arizona Health Sciences. We'd also like to thank our sponsors, which is our UHS Office of Equity, Diversity, Inclusion, particularly Maria Hernandez. Where's Maria? In addition to Elisa on our team, Alma Aguirre, we have Darlene Lopez in the back, a lot of folks that took a lot of time and dedication for this planning that actually started back in 2019, believe it or not. And Daniel Dawes wanted us to be the first campus to unveil his book. But unfortunately, the pandemic hit, and here we are now. And we're so blessed to have him with us today. Our other sponsors are Arizona Area Health Education Centers, the Department of Health Promotion Services, College of Public Health, the University of Arizona College of Medicine, Tucson, the Office of Equity, Diversity, Inclusion, and the College of Medicine, Phoenix of Equity, Diversity, Inclusion, the National Reach Coalition, and the Center for Health Disparities and Research. And again, for the UHS EDI staff and planning committee. So I want to thank them very much. Yeah. And before we get started, we always like to start with our land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to Tohono O'odham and Passamaquoddy tribe. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations, indigenous communities through educational offerings, partnerships, and community service. If there's anyone here that would like to share their indigenous affiliation, please do so. I'd like to thank a member of our team who is from Navajo Nation, so thank you for being with us too. So with that, we'll get started. We'd also like to thank Martha for working with the College of Medicine Tucson to achieve a DEI credit. So those of you that are participating that are from the College of Medicine Tucson, this is what you need to access to receive your credit. This will be available to you at the end of the session today as well. We'll continue to have that posted. So we'll take a few seconds to leave that up for you all.
All right, so thank you everybody for coming today, and thank everybody that's online as well. It's my pleasure to introduce a really good friend of mine, Dr. Dawes. Professor Dawes is the director of the Satcher Institute. He also is a national leader in health equity policy. He was responsible, he played an important role in the Affordable Care Act, in the Americans with Disabilities Amendment Act, and the Mental Health Parity Act. He sits on a number of boards, including the White House COVID Advisory Board, and he's written 3 books, and he's done all of this at a very young age. He's written 3 books that I've used in my classes: 150 Years of Obamacare, The Political Determinants of Health, and most recently, the Satcher Institute came out with a very important report on the economic burden of mental health inequities. So I don't want to talk too much because I know that you guys are going to have a lot of questions for Daniel, and I'm just going to pass it on to.
Let's welcome David.
Thank you. All right, well, good afternoon. Well, I guess it's still good morning, right? Arizona time. Good morning, everyone. Good morning. I know y'all can do better than that. Good morning. Good morning. You know, after escaping COVID for what, 2.5 years, and now escaping a major hurricane, Hurricane Ian, trying to get here, let me tell you how truly grateful I am to see each and every one of you. This has been quite a journey. As Lydia mentioned, when the Political Determinants of Health book was coming out, the framework was being introduced, I wanted the University of Arizona to be the first university that we unveiled it. Unfortunately, we didn't get to make it happen, but I'm still grateful that we're here 2 years out and able to talk about how we can move beyond nibbling around the edges of the problem of health inequities in the United States, and how we can really create the kind of systemic change that is so desperately needed, how we can repair the past, right? And leverage the political determinants of health to make that happen. So we're going to be talking about that today. You know, Martha, where's Martha? Oh, thank you. So Professor Monroy, I just want to thank you so much for the very kind introduction. You are a dear friend and mentor, and I thank you so much for working hard to make this happen. She literally got me on one of the last flights out of Florida so I could get here today, spending, I think, your entire day on Monday to make that happen. So thank you, to the team. Really appreciate the warm Arizona welcome that I've gotten. And like I said, you know, we've had several years of history together, so it is a privilege being here in Tucson, Arizona. So thank you. So, you know, we have a lot to talk about today. And I'm going to start with, in her inaugural poem, how many of you remember Amanda Gorman, the National Youth Poet Laureate? Okay, great. So she reminded us, among countless soul-piercing refrains, that being American is more than the pride we inherit, right? Being American is more than the pride we inherit. It's the past we stepped into and how we repair it. Let's think about that for a minute, right? And so today we're going to look back. We're going to dig deeper than many of us have been able to before. We're going to examine how inequities were concretized in our systems, in our structures, in our communities over time. And we're going to talk about the policies and laws that have propped them up as well. So again, thank you for the opportunity. Let's get into it, right? So many of us have seen the recent headlines highlighting the everyday impact of the political determinants of health, right? And you know, as I think about this period of time that we're in and what it represents, I'm reminded about an experience that I had with my brother, Patrick, many, many years ago. So years ago, I had just gotten my driver's license, and Patrick and I borrowed my mom's car with permission, of course, right? And we decided to visit a new church. Once we got there, we noticed that the only seats available were in the last pew. So we reverently and hurriedly got to the back of the church. We walked to our seats, sat down, and not even 5 minutes passed. And my brother Patrick started to nod off, right? Like so many kids do in church. And I think he was doing that even when you have the best preacher, right? Or the best choir singing. Poor Patrick just couldn't help himself. So when I looked to my right, I noticed my brother's head bobbing as he was nodding off. So I nudged him and I said in a hushed voice, "Patrick, wake up." And he said to me in not so nice a tone, "Leave me alone. I'm tired." Well, a few minutes later, his head starts slowly bobbing again. So this time I nudged him even more and I said, "Patrick, you're going to miss the service. Wake up." At this point, you know, he starts raising his head and his voice in annoyance, and he says, "Leave me alone. I told you, I'm tired." Now, I don't know how many of you in this room today have ever had an experience when two young people are bickering in church, right? But we certainly found out that day when a couple that was sitting in front of us turned around and they shushed us. So not wanting to get into any more trouble, I decided to leave my brother Patrick alone and let him sneak in a little bit of slumber. Well, I promise you, not even 3 minutes passed, and the preacher gets up to the podium and he immediately shouted, "Wake up! We gotta wake up, church!" And my brother, oh my gosh, can you imagine it, right? He jolts out of his seat with his eyes the size of golf balls, right? Embarrassed because he thought that the preacher was talking directly to him. He wasn't though, right? He was talking to the entire church. I share this story really not to embarrass my brother Patrick, but to remind myself and everyone here today that sometimes we all need a serious wake-up call to jolt us into action. And just like my brother's wake-up call in church that weekend, many years ago, right? America has been having a similar experience. You see, by my count, we are actually now in the fourth period of a great awakening for health equity in the United States. So let's talk about that for a moment. So these awakenings have included the first period under President Abraham Lincoln, right? When he created, during the Civil War, the first ever federal policy to provide for the healthcare needs and social determinants of health needs of newly Black freed people and poor whites, right? We saw the second awakening in this country happen in the 1960s with the civil rights movement. And 2 years into that movement, we saw health equity leaders and champions and scholars coming together and saying, wait a second, this discrimination in healthcare, this segregated healthcare environment is unconstitutional. And so they fought to desegregate hospitals through Medicare and Medicaid legislation. Then we entered the third awakening in this country, where folks said, wait a second, why do we see so many striking disparities among different racial and ethnic groups in this country? And so there was then a movement to address the more subtle forms of discrimination in healthcare and public health. And then the fourth period, which is quite interesting because Ken Burns, the documentarian, has said that he believes that we've entered the fourth period of a crisis in this country. I accept that. And I also see the glass as half full and believe that we have entered a fourth period because now we have a federal government for the first time in US history that is harnessing the powerful levers of the government to advance health equity for all population groups, and quite frankly, to address the upstream determinants that have caused, that have perpetuated and exacerbated these inequities in our society. You know, we all know that the long arc of justice eventually does bend, right? The moral arc eventually does bend toward justice. But as it bends, we also know it can wobble, right? And we've seen that in this country. Notwithstanding the fact that we have entered a new period in our health equity movement, a fourth period, according to recent studies, research is showing how little progress we've been making in stemming the tide of health inequities in America. Within public health and healthcare, we are awakening thanks to the groundbreaking research by many of you in this room today, right? Where we're now awakening to the falsehoods, right? How we falsely looked at race as a biological attribute rather than a social construct over hundreds of years in America, contributing to systems of racism in healthcare and education, housing, transportation, employment, and public health. And so I think to address this critical issue and move that needle of health equity to a degree that we have never seen before, it's really going to take greater action from all of us, right? Harnessing the power of collaboration, harnessing our expertise to really help these communities that have been disproportionately affected, quite frankly, for too long. So what does it start with, right? Well, it starts with considering what gives rise to the determinants and drivers of our health. And more importantly, why they have disproportionately and detrimentally affected minoritized and other marginalized groups in this country for way too long. So let's talk about that. So many of you, I'm quite sure, are familiar with the pie chart, these multiple interacting determinants that impact our overall health. And I think many of you too have studied under Professor Monroy and other distinguished professors here and learned that racial and ethnic minorities, people with disabilities, lower socioeconomic status individuals, individuals living in rural and frontier communities, LGBTQ plus individuals and others die disproportionately each year. And we know that the toll that it takes is unconscionable, right? But the one thing that if you don't remember after today's lecture, the one thing I hope you'll always remember is that the nation's health, the United States' health, is not an organic outcome. It is not a coincidence that certain groups of Americans die prematurely in this country, that they are struggling with ill health, right? Why? Well, today we've recognized that there are a variety of forces collectively impacting our health. And key among these determinants are the social determinants of health, right? Which are the structural conditions in which we are all born into, we live in, and we die in, that affect all aspects of our health, well-being, and our life expectancy on this earth, right? Well, of course they play an outsized role, but underlying each of these social determinants and other determinants of health are political determinants that we can no longer ignore. Too often we've been stopping at the social drivers of inequities, failing to look back and dig deeper, right? And really looking to understand the depths and the root causes of this problem. And as a result, we've been missing the link between the social determinants of health and their policy roots. Think about that. For every single social determinant of health in this country, whether it is healthcare, transportation, education, housing, and people's ability to access these opportunities, there was a preceding legislative, legal, regulatory ordinance at the local level or other policy, right? That basically resulted in these structural conditions that we find ourselves in. So I wanted to illustrate this concept with a short story. If you were to envision with me, right, all of society sitting on the banks of a mighty river, fishing and finding nourishment in the resources that the river provides, the health inequities that we face are represented by the differences in the caliber and quantity of fish we encounter. Some people have a bounty of healthy fish, right? Vegetation and other resources to feed off of, while others may only have small fish, no vegetation, or malnourished fish. Different people having access to different types of resources and different parts of the river represents the social determinants of health. Now, some people are located in a slower moving part of the river, right? By no fault of their own. Others are located in more lush parts of the river and benefit because of such, by specific decisions that have been made on their behalf. These are the political determinants of health. You see, somewhere upstream, decisions were made to divert the river to benefit certain people and harm others. And decisions were made to place certain types of people on certain banks of the river while placing others elsewhere. These upstream decisions for centuries in this country absolutely have had and continue to have downstream impacts. You see, this pandemic, this once in 100-year pandemic, this endemic, quite frankly, that we've been in, really demonstrates the inconvenient and harsh truth about the impact that these political determinants of health have and how collectively these factors contribute to our society's health inequities. It shows the compounding effect of political determinants over personal responsibility. I want you to think about that for a moment, right? It shows the compounding effect of political determinants over personal responsibilities. How so? Well, because no matter how hard or how much many African Americans, Native Americans, Latinx Americans, Native Hawaiians, Pacific Islander Americans, lower socioeconomic status individuals, and others try to act responsibly, there are always these structural, institutional, interpersonal, and even intrapersonal obstacles that are in their way, hindering them. Beneath these communities' notice have been political strings, right, that have been pushed and pulled to prevent them from achieving their full health potential. Now, most health equity champions, most health equity leaders, healthcare, public health leaders, and others have been focusing on the social determinants of health, and I think with very good measure. However, we have to really seize this unique moment, right? But really sad moment in our history, and look even further upstream than we have been willing to in the past, and focus now on these political determinants of health. And so it begs the question, what are these determinants of health, right? Well, in our country, the principal roots of current and historical health inequities are found in the political determinants of health. So here's what the political determinants of health. I define it as the systematic process of structuring relationships, distributing resources, and administering power in and across and throughout American society. They often operate simultaneously in ways that mutually reinforce or influence one another to advance or hinder health equity. You see, these political determinants of health inequitably distribute social, healthcare, and other determinants, and they create the structural barriers that basically prevent these groups who lack power and privilege from being able to reach their optimal level of health. So then the next question is, how is it that they've emerged as a fundamental challenge to our collective efforts to achieve health equity? Well, to understand that issue, we really need to go back in history, right? And I really want to go back 400 years. I think 1619 is a very fair starting point, but I'm going to start at 1641, right? We know that the impact of slavery in this country has been, from a research standpoint, associated with long-term impacts on contemporary mortality, poverty, infant and maternal mortality, and the list goes on. And so as we think about the structural conditions in which our communities find themselves in, we need to think about how they came to be in the first place. So let's go back to 1641. This was the time now when the commercial interests, right? Wanting to maintain their business model of slavery in America, worked with the policymakers in Massachusetts first to create the body of liberties law, right? Then the business interests and policymakers in New York, Maryland, Connecticut, and other colonies said, wait a second, we should use that as a template. And they worked and revised it and also passed the law legalizing slavery in their communities, in their states. Well, what's really interesting too is that when the abolitionists at the time were making headway and saying what an evil institution it is, right? How dare you enslave God's children, right? How dare you do this? And they were making headway in their advocacy. The business interests then worked even more so to ensure, right, that the offspring of these enslaved families would also themselves be deemed slaves under the law. And as if that were not enough, what did these policymakers do? They went about creating additional policies that made it so difficult, that restricted Black and Indigenous groups from being able to raise their own food, earn their own money. They were prohibited by law from learning to read and write. They were prohibited by law, depending on the jurisdiction, from going beyond a 1 mile radius, right? And if they were Black or Indigenous, they had to have permission slips, right? They had to have lanterns if it was at nighttime. The list goes on. We saw those laws being recycled from one generation into the next, from the 1600s into the 1700s, impairing these groups' ability to be able to achieve health equity, right? Then we saw now a movement into the 1700s, right? In the late 1700s, once the United States government was formed as a constitutional republic, we saw abolitionists saying, wait a second, we need to get the federal government to move on this agenda, to provide for the general welfare of all people, especially the most vulnerable people in our society, people with mental illnesses and substance use disorders, homeless individuals, and others who have struggled, right, in our society. Well, we know what happened there. That was ignored. We get into the 1800s, and it would finally take a major war, the Civil War, before the federal government, before our policymakers, before our leaders in this country were able, right, to negotiate the first federal policy, not only abolishing slavery, but providing all of the things that folks in the 1700s have been trying to, the abolitionists have been trying to provide food and clothing, to provide healthcare services, to provide housing and education and true employment opportunities for not only newly freed Black people, but also poor whites who were displaced as a result of the Civil War. Interestingly enough, they accomplished that, and I'll go into detail a little bit more about this, But we saw a backlash, right? Once that law was passed, Abraham Lincoln was assassinated 4 weeks after signing this bill into law. And we saw things starting to unravel after his death, right? Well, this then brings us to the period of Jim Crow, right? Where slavery showed us through epigenetic research that there's this intergenerational trauma that we have seen from that period, right? In many of these vulnerable and marginalized groups. We then saw during Jim Crow, when it raised its head with a vengeance at all levels of government now, local, state, and federal, with the onslaught of policies that were created again to restrict Black and brown individuals in this country from being able to exercise their right to vote, to own property, right? To really address their social determinants of health needs. We saw that now moving full speed ahead. And we have seen the impact, again, from a health standpoint, direct link to aggressive breast cancer prevalence among African-American women. They have the most deadly form of breast cancer in this country, triple negative breast cancer. Again, it is owing to the racism, the sexism, everything, right, that they've had to endure. And so let me bring us from the 1800s into the 1900s, because this is a really interesting time, right? We move from what we call explicitly racist policies that excluded certain groups of Americans to now what we call facially neutral policies. But they had the same intent. So these policies, think about the Social Security Act, for instance, they're designed not to explicitly exclude a certain racial or ethnic group in America, but they are created, they are designed, so once they are implemented, they actually have the same effect. They exclude these groups. So the Social Security Act is a great example of that. When it was devised, they intentionally wanted to exclude agricultural workers and domestic workers. These were largely African-American. In fact, 75% were African-Americans. And then, of course, large amounts of Latinos, Asian Americans, Native Americans, and others, right? So it was designed to make sure that this social, right, and economic policy would not benefit the very people who had, again, been struggling in our society. Well, after that, we then see another period in US history where folks have said, all right, we can't create racist policies, but we need to think more creatively about how to design them so that they have the same effect. And one such policy was the Homeowners Loan Corporation Act, the HOLCA. This occurred after we went through World War I under the Franklin D. Roosevelt administration. And what's fascinating about this was we've gone through this major world war. The country now is suffering from an economic and national security standpoint. And folks were losing their homes, kind of like the Great Depression, right? People didn't know what to do. The Franklin D. Roosevelt administration said, we've got to do something. Well, they decided to create this law, get it passed in Congress, and it basically authorized property appraisers working in conjunction with state and local policymakers to go into the neighborhoods of these states, right? Into over 200 cities, and to grade them on an A, B, C, or D scale. They also color-coded them. Your A communities were color-coded green, B was blue, your C was yellow, your D was red. The A communities were your affluent white communities. Your B communities were your middle-class white communities. Your C communities were, quote unquote, declared undesirable immigrant communities. These were your largely Mexican or Central American, Cuban, Italian, German, Irish communities, Jewish communities that were deemed basically undesirable. And then lastly, the redlined communities or red communities, your D communities, were your predominantly African-American communities. And these were classified as hazardous. So what did this mean? After all of these reports were conducted, as studies were conducted in the cities and these neighborhoods, they were compiled, they were then sent back to the federal government, where the White House at the time used it to determine who to give federal home mortgage loans to, right? VA and FHA loans. And they decided that all of these red line communities were too risky an investment. So they decided to enact another policy based on that report to exclude African-American and Latino and Asian communities from getting the federal loans. Interesting history, right? What I find also interesting was that the groups in these neighborhoods, right? that were already starved of resources by acts of law and policy were then again further starved of resources that they needed, right, to have a piece of the American dream and to realize their full health potential. So then it brings me back now, afterwards, we're in the 1950s. We just go through another World War, World War II. The country is on its knees in terms of a mental health crisis, right? 20% of young people between 17 and 24 had PTSD. They were unfit to serve in the military. 40% of young people were leaving the military. 60% of our hospital beds were being occupied by people with mental illness. It was a very terrible time from the records. And interestingly enough, what occurs right after that now was we have this economic and national security crisis again. And the federal government was trying to think about what they could do to stimulate the economy. And so they came up with the Highway Act, right? And the Highway Act, for many of you who work in Black and Brown communities, you may have noticed in these communities a major highway splitting the neighborhood in half. How many of you have ever seen that? Yes? Okay. It's owing to this 41,000-mile network, interstate network, right? And it's been interesting as I've traveled around the country and spoken to folks in these communities, and I say, how did I get there? No one can recall. Nobody can recall, except for those who are much older and were there when they were children and said, oh my God, I remember when I was a kid and we were in the house, a house that used to stay right there, was right there. And we had folks knock on our door, my parents' door, and tell us we had to move. We had so much time to leave. That Highway Act displaced, as it was implemented by state and local governments, it actually displaced 500,000 Black and Latino population groups in the United States, right? Displacing over 500,000 people. Then they created the Housing Act. And in the Housing Act, what I find really interesting about that too, was that the federal law, again, implemented at state and local levels, allowed the local and state governments to take away, by eminent domain, take away the properties that some of these Black and Brown communities were able, miraculously, to get their hands on, right? It took it from them, sold it very cheaply to real estate developers, who then in turn made housing for more affluent communities, right? So again, you're disrupting a critical social determinant of health factor. Well, we've seen then afterwards, a host of other policies that were created afterwards, and they've been recycled. They've been impairing our ability to really advance health equity in these communities. And today we now see a poverty tax essentially in these communities in the form of higher payments for auto insurance or home mortgage loans, lower property appraisals. I'm sure you all read the newspapers and I continue to see that, right, happening in these communities. We've also seen this movement, right, towards these deserts. In many of these neighborhoods, I've been in Flint, Michigan, and my God, that place caused me to cry. I couldn't believe what I had witnessed, right? The food, the pharmacy, the hospital deserts, making it so difficult for many of these communities to access, resources to improve and maintain their health. And what we also have seen is where the federal government led. A lot of people think it was the commercial interests that led basically the disinvestments, right, in these communities. In many respects, the federal government instigated it. The commercial interests then followed suit, and these grocery stores, these pharmacies, these hospitals said, well, if the federal government or the state government isn't going to invest in these communities, why would we ever do such a thing? That would be a poor return on our investment, they said, right? And so for generations, they also neglected these communities. What we're also seeing today, as we face this existential threat of the climate crisis, right, is this movement from redlining to blue lining, right, in the form of climate gentrification. And what I find very interesting as we are continuing to track the effects of this movement is there were state and local restrictive covenants that made it very difficult for Black and Brown individuals to purchase property, let's say by the seashore, right? And all of a sudden, as the sea levels are rising, whether in Miami, St. Petersburg, Baltimore, wherever, all of a sudden, these communities that were decades earlier forced to move inland onto higher elevated lands are now being pushed out by those who were residing at the sea as the sea levels rise, again, displacing many African American, many Latino and other groups in this country. Something to think about as you advance in your careers in public health and healthcare. They all collectively impact the health of your populations and communities. Well, what's very interesting about all of this now is that all told, you can see the impact, right? That the political determinants of health have on communities of color, have on rural communities, have on lower socioeconomic status individuals. And I love this quote by Professor Michael Marmot out of London, really one of the pioneers of the social determinants of health framework. He says that life expectancy as a measure of health tells us a great deal about how we are doing as a society. However, the inequalities in health tell us even more about that society. Where you live in this country absolutely matters to your health, your well-being, and how long you're going to live on this earth. It absolutely matters. You know, you can see the neighborhoods that were redlined, right, on this map, that were starved of resources by acts of law and policy, are now the very communities that are losing a generation. They die off much younger than the rest of the population. Think about that, 20 plus years in certain jurisdictions. Here I highlight Tucson and Phoenix for you, so you get a sense of how this has impacted the health of minoritized groups. Well, we know that policy has been a driving force in this nation's history for many of the health inequities that we see or have experienced over time, right? But I also believe that it can be used to advance health equity in America, because only policy can fix what policy has created in the first place, right? So let's go back a little bit more in history for a moment, because I've had folks who've said, you know, Daniel, nice try. You started 1641. We weren't even a government yet. We weren't even formed as the United States of America. So that's not a fair starting point. And I said, all right, fine. Let's start at 1789 then, right? When America was founded. And let's talk about this for one moment. I quote the famous, the notable Southern writer, William Faulkner, where he says, the past is never dead. It's not even past, right? And how true is that as we've gone through the last 2 years and we've witnessed and our eyes have opened to the social injustices in this country. So let me take you back to 1789. I don't have time to go through these three independent health reform campaigns around mental health, minority health, and universal health. I want to stick to minority health though. And I'm going to start when a group of abolitionists, and I'll talk about when all of these different campaigns got together. Advocates for homeless populations, advocates for folks who are struggling with mental illness and substance use disorders, abolitionists and others who are fighting, right, for the rights of Black enslaved people in this country, for indigenous population groups and so forth, coming together and saying, wait a second, we need our new government to provide for the general welfare of all people, not just a select group of people, not just those on the upside of advantage and opportunity, right? And so they worked together and they started strategizing. And in their strategy sessions, they recognized that they wouldn't be able to move the agenda forward unless they recruited a major policy influencer. And so they decided to approach Benjamin Franklin. And they said, Benjamin, would you please lend your name, right? Your power and influence to the cause, and sign your name to a petition that we want to send the US Congress. And although Benjamin Franklin had been a lifelong slave owner, right? Interestingly, as you end the near, as many of these men were ending their lives, it's amazing how they tried to rectify what they did. And Benjamin Franklin said, you know what? Absolutely. This is an injustice and we've got to abolish it. So he lent his name. They crafted a petition. In the petition, they basically called for the federal government to stop slavery, to abolish slavery, to stop the separation of children from their mothers, the breakup of these enslaved families, to provide housing, to provide food and clothing, to provide healthcare services to these populations, right? And in that petition, when it was received by the House and the Senate, my God, if you think we're having a very contentious debate during this period of racial awakening in this country, it seems to me from the records that it was equally, if not more contentious, because folks said, how dare you, Benjamin? How dare you, reformers, bring up this issue when you know that we're just getting settled as a government? Now is not the time to be talking about race and slavery and all these issues. Now is not the time to be talking about these vulnerable groups. What are you doing to us, Benjamin? Well, the Senate decided they were not going to dignify his petition with an answer. But the House said, we can't let Benjamin get away with this, right? And so in bullet by bullet, the House actually went about making an argument for why they could not provide for the general welfare of all people in this country. They made essentially a confederalism argument. Their argument was, and they punted the issue essentially, was that the states are closest to these people. Therefore, they know what's in the best interest of these people. We're too far removed from them, right? We don't know what's in the best interest of these enslaved Black people and indigenous groups and other minoritized groups in this country. And so they made that confederalism argument, punted it, and unfortunately, that was the first time that the light of health equity had dimmed in federal policy efforts, right? And 3 weeks after receiving the response, Benjamin Franklin passed away. So the movement lost an incredible champion for health equity at that period. Well, it would then take us 75 years later for the political stars to align in this country. And it would take a major war, the Civil War, right? For our policymakers and our commercial interests and leaders across the nation to recognize, wait a second, this is not sustainable. This is a huge crisis. And so in so doing, President Abraham Lincoln worked with the radical Republicans at the time, right, his supporters, and they actually developed the Freedmen's Bureau Act, the nation's first, most comprehensive and reticulated health policy, addressing the social determinants of health needs of not only newly freed Black people, but also poor whites and others across the country, right, that were impacted by the Civil War. In it, they actually included provisions that those in 1789 had tried so desperately to get in policy. They included provisions around food and clothing, housing, education, true employment opportunities, even national security. But there was one provision that was too contentious for even Abraham Lincoln to push his supporters on, and that was to provide healthcare services to these disparately impacted groups, right? So, in the spirit of compromise, after 2 years, as the Civil War was winding down, President Lincoln says, all right, guys, enough is enough. Let's compromise, get that bill passed, and I will sign it into law. And so they struck the healthcare services provision. They left everything else intact. He signs it. And then what happens 4 weeks later? He is what? Assassinated. Exactly. He was shot. And his supporters, not wanting to squander the opportunity that the crisis presented, said, wait a second. We believe that upon rereading the Freedmen's Bureau Act, that it does authorize us to provide health services to these newly freed people and poor whites, right? And so they went about recruiting healthcare providers, nurses and physicians and others from the North into the South. They established sanitariums, hospitals and clinics, right? Other healthcare entities in the South and in the Midwest and so forth to provide healthcare services to these newly freed people and poor whites. But what happens? We've seen over the last 2.5 years that hate never takes a break and racism never sleeps in this country. And that's exactly what happened after President Lincoln was shot. We saw folks who were opposed to this health equity agenda fighting tooth and nail to undermine the Freedmen's Bureau Act, to undermine all of the civil rights acts that were created to allow every population group in this country to be able to exercise their right to vote, to participate in our government, right, and in our political process, to make sure that they were given a fair opportunity, right, to reach their full health potential or their full potential. And so after that period, we then saw the period of retrenchment, like we do in every single period in this country's history when there is a great awakening for health equity. There's serious retrenchment, backlash, right? Regressive devolution that occurs because folks don't like it when you expand the umbrella and you share the resources, essentially, right? So after that, 7 years after the law was passed, unfortunately, opponents of health equity won the battle, and they actually succeeded in dismantling the first federal program to provide for the social determinants of health needs and health services needs of these vulnerable groups. It would then take us 150 years afterwards for the political stars to align again, this time under the presidency of Barack Obama, for us to get another bite at the apple. And in that period, as you heard, I'd gotten the chance to work with the White House on creating Obamacare, the Affordable Care Act, the most comprehensive health reform law, health equity focused law in this country. We did that because we had leadership that understood, right, that if we didn't tackle this issue, things were going to get worse before they get better. We actually worked with military leaders, generals and admirals and others to create a study looking post-World War II now, right? 1946, you remember the study I outlined with 20% of young people unfit for the military? We recognized that the only way that we've been able to get health equity focused policies passed, over the finish line, implemented and enforced was when we tied them to an economic or national security argument, right? The moral argument alone has always been insufficient in convincing our federal government to act. It has to be moral argument and one of these issues. So we decided, recognizing that the Obama administration, folks, many of which had participated with Hillary Clinton and President Clinton on their health reform proposals, they were extremely nervous about expanding the scope of this health reform law. They did not want to include an agenda that would eliminate inequities across different races and across different disparate groups, whether sex, sexual orientation, gender identity, and so forth. They didn't want to go there. They thought it was too contentious. But we got this study done, and what we found was even more frightening in 2009 than in 1946. This time in 2009, 75% of young people between 17 and 24 were deemed unfit to serve in the military, owing to higher criminalization records, right? Or obesity, mental illness, and so forth. And we said, okay, this doesn't get the Obama administration to recognize that this is worth continuing to address, then I don't know what is, right? We were quite surprised, or concerned, I should say. So we shared the report, we shared the findings. Thankfully, that was enough to keep us at the table, right, and convince the Obama administration that this was an agenda worthy of inclusion in the health reform law. It would eliminate, it would bend the cost curve, it would help to increase and improve the health outcomes. There'd be tremendous cost savings, and there's positive national security implications, quite frankly, right? Because if these young people are coming from communities that are sicker and dying prematurely, well, how are they able to outcompete our global competitors, right? How are they able to defend this nation from external threats? So thankfully, that allowed us to remain at the table. There was another study that we did that showed that for racial and ethnic disparities in this country, between a 4-year period, we actually had spent over $300 billion because we neglected to address the issue. $300 billion, enough again to get officials in the Congress and the White House who are working on the health reform law to continue this agenda. Well, we finally get that done. And today I'm really proud that we managed during that negotiation to retain 62 health equity provisions, health equity focused provisions in the law, right? That is intended to elevate the health of every single one, whether you are white, Black, Hispanic, Latino or Latinx, whether you are Native American, Pacific Islander, these provisions are intended to elevate every group in the country. So let me, in the few minutes that I have left, talk about how we can leverage the political determinants of health, right? We've talked a lot about a history. Let me bring us back now into our current reality. So we talked about this definition, and I see this really as a tripartite definition of 1, structuring relationships, 2, distributing resources, and 3, administering power, right? We talked about structuring relationships with the Homeowners Loan Corporation Act that redlined the United States. But there are a host of other laws that have been developed intentionally to structure relationships in this country. The anti-miscegenation laws that were designed to prevent whites from marrying with Asian and Black and Latino populations. For those of you who work with Native American communities, the blood quantum requirement laws, right, that were developed by the Dawes Commission, again, designed to water down their blood quantums to prevent them from marrying outside of their communities. We've seen the policies, for those of you who work with children with disabilities, the laws, the policies that were on the books that denied people with disabilities an opportunity to receive an education in schools. Or how about even today, those policies at the local jurisdictional level, right, that prevent people with disabilities from gaining access to housing, right? And then we can go in a host of things with the federal recognition versus non-recognition of tribes and so forth. Distributing resources, right? We're here in Arizona. The Garrison Dam is an incredible example of how resources have been distributed. And we talked about, in the beginning of my lecture, this idea of all of society sitting on the banks of a mighty river, right? Think about the Garrison Dam and think about the O'odham Indian tribe, right? And the Pima Indians and others who for centuries had been engaged in raising their own food, had been engaged in some level of farming. And then all of a sudden one day, these policymakers come and say, no, we're gonna dam the river, right? Preventing the river from flowing into their community, giving them this critical element of life. And what we saw happen afterwards now was this community having to do what? Get food from the outside, get junk food, get fast food, get whatnot. And today they have the highest rates of diabetes in the world. Think about that. Here in Arizona, that's outrageous. But again, we have to think about how is it that we see these poor health outcomes when they weren't there before they dammed the river? How did it come to be in the first place? We need to continue to go further upstream to the source, to the cause, the fundamental cause of these inequities. When we think about administration of power, right? Perhaps the most contentious of this tripartite definition, we've seen and heard at late these major Supreme Court decisions. There's an interesting case right now that has happened in Mason, Tennessee. This is a predominantly African-American community that was struggling financially. And Ford Motor Company says, we're going to build a facility in your community. And what does the state do? The state decides, they didn't like that idea, right? They wanted to control this Black community, this government of Black leaders. And so they decided to demand that the leadership in this community give them their charter, right? Or they would have to pay back the debt that they owed the state of Tennessee. Well, thankfully, you had a group of committed leaders that say, this is unconscionable, this is unjust, and they fought back at the state, leveraged their advocacy to prevent that from happening, from the state taking them over. We've also seen the Supreme Court decisions. There's one that I'm watching very carefully that came out of North Carolina that is really going to impact our ability in this country to go out and vote, that will impact voter suppression in this country. So something to take a look at. But When you think about redistricting, gerrymandering, restricting ballot access, voter suppression tactics, or voter identification laws, all of these have health implications. Not being able to vote can mean the difference between life and death for these communities, right? If you prevent them on the front end from being able to engage in the political process, right? As this government develops, as these decision makers are placed in power and develop policies that affect every single one of us, if they are not able to engage in the beginning, right, in this process, my God, it's no wonder the policies have been created that actually have excluded them for centuries in America. So, now today, this is really my wonky framework based on a legal, political science, public health, historical lens. And I think today we can see clearly, right, the negative effects that these policies and laws and the infrastructure changes have had in these communities, right, especially the health of racial and ethnic communities. We have seen how the higher rates of asthma started to escalate among racial and ethnic minorities when these highways were then all of a sudden built in their communities, right? Increasing the polluted air that they were forced to breathe. For those of you who come from New York or have visited Manhattan, in Harlem, 6 of the 7 bus depots were placed in Harlem, a predominantly African-American community. Again, intentional, right? And what have we seen? We've seen children have the highest rates of asthma in the country. Again, they're breathing in the most polluted air. We have seen railroad tracks, again, right, that were placed, again, increasing respiratory ailments in these communities. And we've seen these other infrastructure, factories and whatnot, increasing rates of cancer and diabetes, just to name a few. So think about that as we are thinking about that whole ecology of the system. So, when I think about these issues today, against the backdrop of all of the racial injustices that we've heard about nearly every week, or the COVID pandemic that we hear about every day, or even, the efforts to stall voting rights, which we hear about every hour. All three of these moments really have a disproportionate and extremely harmful impact on the health of African Americans, Latinos, Native Americans, and other people of color. They also, in a very real and indirect ways, serve the detriment of our collective efforts to achieve health equity in this country. And I've come to realize that the complicated origins of events that occurred in the past really do explain the complicated present times that we're living in today. And so, these 3 moments, while they're major concerns with which we all contend now, they are rooted in the political determinants of health that I just highlighted, which really started so far upstream, so long, still today, here we are, right? So far downstream, wading in these troubled waters, trying to figure out what to do. You see, over the last 233 plus years, this nation and its leaders have really tried to integrate principles of equality and equity into laws and policies that directly impact all of us. And as I mentioned, there have been some successes, but far too few have armed the broader community of healthcare providers and public health leaders knowledge and perspective that they need to more meaningfully advocate and advance health equity. So where do we go from here, right? As a community of health equity scholars, champions, and leaders, where do we go from here? Well, we all know that there is no single answer, right? And righting the wrongs that have created and have been perpetuating and exacerbating these health inequities that we see today is going to take some time. Lives are quite literally hanging in the balance, right? It is really my hope today that my remarks this morning are received and interpreted exactly as they are intended, as a multi-pronged call to action to reshape, reform, and even modernize our approach to health injustices and health inequities by addressing the fundamental causes the root causes and drivers of these health inequities. And I know that we have the most respected, some of the nation's most respected scholars and learners, leaders in this room today, right? That we are engaging in this conversation today really does give me hope. It gives me a hope that we can do so much today. You know, when someone told me that when ordinary people come together, extraordinary things can happen, I find comfort in knowing that I'm speaking not to a group of ordinary people, but to a group of extraordinary people, which lends me to believe this, right? That when extraordinary together, magic in health equity can certainly happen. And I hope today that we have such leaders in this room, because as my dear friend, Dr. David Satcher has reminded me, he was a 16th Surgeon General, really dedicated his life to fighting racism in this country, to fighting to eliminate health inequities. He says what we need now more than ever before, especially during this fourth period, are leaders who first care enough, they know enough, they have the courage to do enough, and they're there until the end. First, you got to care about these communities, right? But as we have seen, caring is not enough. You also need to avail yourself of these upstream determinants, of these political drivers of inequities. And as you have also heard today, this is not a movement for the faint of heart, right? We know that racism doesn't sleep and hate never takes a break. You have to develop the courage if you want to embark in this journey. And you have got to until the job is done. Because what we have found is whenever there are these periods of retrenchment and backlash, a lot of health equity scholars and leaders bow out, right? They've lost the will to continue to fight the good fight. So I hope today that we have leaders in this room who fit all of those four elements. Thank you again so very much for the privilege of your time and attention and the great work you're doing. I appreciate it.